Fighting Blindness Canada's View Point is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by AGTC, Allergan and Abbvie Company, MeiraGTx, Novartis and Roche. We'd also like to thank Accessible Media Inc., our national media partner. Everyone here should download the AMI app, which is a fabulous resource. And you can watch excellent programming, including previous Fighting Blindness Canada events. Thank you for watching. We hope you enjoy this webinar and share your thoughts with us in the comment section below.
So we are going to now talk about genetic testing, and we have a variety of perspectives up here today. So Dr. Kevin Gregory-Evans is joining us again, and then to his left we have Emily Alderman, who's a clinical genetic counselor with the Provincial Medical Genetics Program at BC Women's and Children's Hospital. And then on her left we have Allan Dias, who Allan and I just sort of met in the last couple weeks, and it's a great story, and I asked him to join us today to talk about his perspective. He's an accessibility advisor at the University of British Columbia and has lived experience with low vision due to Leber's. So let's get started. So Dr. Gregory-Evans, if I could start with you, can you tell us a little bit about what is genetic testing and why is it so important?
Thanks. So molecular genetic testing for inherited eye diseases has only really been available in British Columbia over the last 4 years. Before that, the province wouldn't fund genetic testing because of their concepts of the value of genetic testing in this particular cohort, which is interesting because clearly over in Quebec and Ontario, they felt very differently and have been genetic testing there for about 10 to 15 years. But at least we have it now. And over the last 4 years, we've done genetic testing in about 700 people so far. So certainly it is something that's now available, and I would encourage everybody to have genetic testing for their eye condition. There are two reasons to have genetic testing. Genetic testing beyond genetic counselling and to some extent predicting disease progression are the only reasons to have genetic testing today. But there is even more benefit to genetic testing in the near future. In particular, genetic testing is the gateway to clinical trials, especially for gene therapy protocols. But it's likely that genetic testing will not only be necessary for all clinical trials in inherited eye disease, but probably when therapies become available to regular patients in regular clinics, genetic testing is going to be needed as well, because it's likely that a genetic test will be the gold standard for a diagnosis for an inherited eye disease. To some extent, we can make a very accurate diagnosis based just clinically, but I suspect for emerging therapeutics of the future, especially the most expensive genetic therapies, we're going to expect to have a molecular diagnosis. So there's some benefit to having it done today, but there's enormous benefit for the future. So I would encourage everybody to have genetic testing.
Great, thank you. So Emily, can you tell us a little bit about what you do as a genetic counselor?
Am I close enough? There we go. Okay. So my work at the Provincial Medical Genetics Program, it's housed out of BC Children's and Women's Hospital in Vancouver, but we serve the province. Aside from the island, they have their own genetic service in Victoria. But so as a genetic counselor, I'm kind of part of the genetics team. So I kind of introduce myself a little bit as the nurse of the genetics world, although I don't have a nursing degree, so I'm not practically useful from that perspective. But I work in a team with a geneticist, and she's the doctor of the genetics world. So in the context of inherited eye conditions, typically patients are coming to us with a clinical diagnosis made by their ophthalmologist, and they're asking us questions like, what is the underlying genetic cause? Can you identify the specific gene or the specific, you can think of it like a spelling mistake that has caused the eye disease in me or the eye disease in my family? And so that's kind of where we come in is, what is the most appropriate genetic test for you? How do we get that done? And then once we have the results, what do the results mean? What do they mean for that person themselves? What do they mean for family members? And is there anything useful we can say about what, just like Dr. Gregory-Evans was saying, what will this look like in the future? So my specific role is in basically when someone comes to see us, we'll collect medical history, family history. We want to know what that person's ophthalmologist is seeing. What is the clinical diagnosis based on that person's features? And then based on that, what is the best genetic test? How do we make that happen? That's kind of us. We make it happen. Although we're not the only source of genetic testing. A lot of the ophthalmologists are doing it as well. For example, but often for ophthalmologists who are not as comfortable with genetic testing, they'll send their patients to genetics, and we'll organize genetic testing and then talk about the results and then talk about what that means for the rest of the family.
So you mentioned a geneticist. So when would someone see a geneticist versus a genetic counselor?
Yeah, so a person would need a geneticist if they're in need of diagnosis, or if they're in need of a physician to make recommendations around treatment or monitoring, basically. So medical management and diagnosis. You need a doc. So in the scenario where someone is coming to genetics with a very clear diagnosis from their ophthalmologist, then you're likely to see a genetic counselor, because it's not so much about what is going on for this person, it's more about, can we identify the underlying cause for their diagnosis. But if a person does not yet have a clear diagnosis based on the features that they're experiencing, then you may end up seeing a geneticist.
Great, thank you. So this question is, I guess, for both Emily and Dr. Gregory-Evans. So if a patient decides that they want to get genetic testing, how do they then go about that?
So from my perspective, a patient needs to get a referral from either their ophthalmologist or their GP or their optometrist. When it comes to healthcare and the eye, we shouldn't underestimate the skills of optometrists in making diagnoses. I think that they're an important part of the whole healthcare system for the eye. So referrals from optometrists often are, better quality than we get from GPs, basically, because at least the optometrist will have looked in the eye, whereas a GP probably won't. So I think optometry referrals are important. And then from my perspective, looking at the history and the clinical examination and the results of investigations, I then decide whether to offer genetic testing or not. Remember that inherited eye diseases are important to this group here, but when it comes to retina diseases in their entirety, they're only a part of what's going on. So it's important to understand that when you see retinal disease, it isn't always genetic. In fact, most of the time it isn't. And sometimes it can be quite difficult to differentiate between the two types. So for instance, retinal vascular diseases, inflammatory diseases, past trauma to the eye, all these things can look like retinitis pigmentosa, essentially. I remember a patient that I saw years ago back in London who was coming along. This was an elderly man who had dementia, who had come not for a diagnosis or for genetic testing. It was his grandchild wanting to know why, what the risks were to her children, of her children having her father's condition. And to cut a long story short, this grandfather looked like he had retinitis pigmentosa, but actually had neurosyphilis. And his dementia and deafness were not due to old age. It was because he'd been misdiagnosed for many, many years and had never been treated. So it's important to remember that we do need to make that differentiation. And sometimes it's easy, and sometimes it's very hard. Molecular genetics is becoming a useful tool in making that differentiation. But in my dealings with the province, because testing is quite expensive, relatively expensive, they don't want to see molecular genetics as a screening tool for retina disease. They want somebody to have at least one other bit of information to support that. And often that is either from the clinical exam or from the investigations. There's something else that's positive. A family history, too, is a positive thing that would then move us into molecular genetic testing.
Yeah, and from our perspective, it's very similar. People come to the genetics clinic with a referral from their family doctor, from their ophthalmologist, from their optometrist. That's how you end up seeing genetics.
Yes, and for anyone who's interested, well, we did earlier, I'm not sure if there's still any, but on our FBC table at the back, we do have some copies of the guide to getting genetic testing specifically here in BC, and it is also available on our website if we don't have any more copies back there.
I read it, it's very good.
So Allan, if I could come over to you, could you tell us a little bit about how you were diagnosed and when and why did you decide to get genetic testing?
Yeah. So like a lot of other folks with an inherited eye disease like myself, I like to compare it to just, the frog that's in warm water that it slowly boils. You just, it's a gradual process that's happening over time. For me, I probably noticed it in my teens, driving or learning to drive, and wow, I'm missing a lot of stuff here. But I still want to get through this because my friends are going to the bar and club and they need their license to get in there. So that's what motivation to get it. But afterwards, chose never to drive again because it just wasn't safe. For me, it came to a head that something significantly was wrong because maybe a few months after my 30th birthday, I was, downstairs, open a book, and I can't make out the text in the book. I could yesterday. I don't understand why. I know my vision has been great. I open up my laptop. I see this glowing square. I, again, don't understand what's going on. Maybe a week later, I found myself in some specialist office, actually just down the street, and the fellow was saying, oh, you have placoid something or other, which he was wrong, and that's why the name didn't stick. Asked me what I did, and he said, and I told him, hey, I work at a university, I help students find work, and he's like, well, your career's likely done. And I'm like, well, thanks for your amazing advice. I, of course, sought out another referral. And I found Dr. Merker at West Coast Retina, which folks might have heard of, I don't know. And he had diagnosed me with RP, but he was a little confused because it usually doesn't drop like that, right? A miraculous thing that happened after that, not in a good way, is my wife, her kidneys had failed maybe about a week or two after being diagnosed, shortly after all this happened. And a horrible scenario, timing was terrible. I found out I was a potential donor and ended up donating about a month later. I think it was October 31st. And still going great with her, and surprise, surprise, we're married now. What a shocker, right? And that wasn't a requirement, by the way. But a couple weeks later, a good chunk of my vision returned, which was really unusual. And even Dr. Merker was scratching his head going, I don't know. But ever since then, it was a slow loss of vision. And at that time, I was, poking around, looking around to see what sort of resources are out there in terms of getting diagnosed. Not diagnosed, pardon me, treated. And Dr. Merker had said, hey, I am familiar with another fellow, Dr. Evans, you may know him too. And he's quite knowledgeable about clinical trials. And I found Dr. Evans, and he had let me know about genetic testing. And I thought, you know what do I have to lose? And at the time it wasn't funded. He graciously found some funding for this to happen for me. And I remember meeting him later, and he sits down, he opens up the paper, he looks at me, he goes, you thought you had RP, right? And I said, yeah. And he goes, no, you got Leber's, or Leber's, some people refer to it as. And I'm like, oh, good to know. What does that mean? And of course, very, very similar functional impact of the disease. But the important thing is also had a label to something, and always struggled identifying what this was. And genetic testing helped do that, and helped with that journey in terms of seeing what sort of clinical trials might be relevant to me. So that was a big motivator for me. And, just it's nice to have a label to something.
Great. Thank you so much for sharing that story. So interesting, Dr. Gregory-Evans, we talked to some people too that have said that, they had genetic testing, but it was so long ago. How have things changed over the past, say, 15, 20 years? If people have been tested in the past, but maybe didn't get a result, is it worth it for them to look at getting testing again?
Yeah. So when patients tell me that they've had testing done a long time ago, like more than 10 years ago, it's most likely that that testing was done via a research project, most likely. And for lots of very good reasons, we can't use the results of research genetic testing in clinical practice. Mainly because the standards by which that genetic diagnosis was made are not at the higher level that you need for genetic counselling, for instance. So a lot of the time, that information is not relevant anymore, and it needs to be repeated. The second thing is that most genetic studies that are done in eye disease screen candidate genes. And the number of genes that are screened is increasing all the time. If testing was done in the past, and again I say like 10 years ago, 15 years ago, it's likely that the panel that was used was just perhaps 10 genes. Now we can screen almost 300 genes. So negative data from the past definitely doesn't mean that it's going to be negative again. In fact, it will most likely be positive. The hit rate in my clinic for a positive genetic diagnosis is about 85%, which is a lot better than it was in the past. The other thing to say is that, and I suppose we'll be talking about it later, when somebody, so I had this recently. A patient told me that they'd had whole exome sequencing, and the result had identified a particular gene, and why don't I just contact that doctor and ask them for the result? So I did that, and the response I got back was, I don't know what you're talking about. Nothing like that was ever done. So sometimes people have had genetic tests, think they've had genetic testing, and they didn't. They didn't at all. So having a negative result from the past doesn't necessarily mean that that the gene isn't known. So I think it's important to, if you've got a positive, even if you've got a positive result from the past, probably we need to recheck it. And if you've got a negative result from the past, currently it's well worthwhile having that test done again. Now I mentioned whole genome sequencing, and this is something that's offered through medical genetics, which I don't offer. And I don't offer it because of bioinformatics, that the laboratory side of that type of testing, where basically all genes are screened. The biochemistry and the lab work for that is very well established, and there are very big, expensive machines to do that sort of work. But the difficulty is interpreting the data. From one whole exome sequencing we did in a patient, we came back with thousands of potential causes for their eye disease, and we had no infrastructure in order to be able to work out which of those thousands was the actual one. So bioinformatics is a science that's still in evolution, and the Children's Hospital is at the forefront of those developments. But from my perspective at the moment, that sort of work isn't really ready for inherited eye disease outside of a research project. If it's a research project, that's different. That can be done. But if it's for regular patients, I still stick to candidate gene screening.
Yeah, and that's the approach we take most of the time. The kind of the 300-ish known genes that usually match fairly closely with the description of someone's eye condition is usually a sufficient net for identifying the underlying genetic cause. We generally don't throw that big of a net like in whole exome sequencing unless we're really unsure what we're looking for. And that's rarely the case when someone is fairly well but it has the suspicion of an inherited eye condition. So for most of the time, we're doing the same thing as you. Part of what Dr. Gregory-Evans was talking about is sort of like the three possible results we might get from genetic testing. Either results come back completely normal, we have no idea what's causing that person's eye condition, or we get a clear genetic test result where there's a spelling mistake in a specific gene, it matches well with what their own history of eye disease has been, it matches well with the family history, we're pretty sure we found the cause. There's also an uncomfortable middle result where we've found, we call them variants of uncertain significance. So we've found a spelling change that's different from kind of the human reference sequence. And I'm using air quotes because we all have spelling changes that are different in our genetic material, thousands that are different from the standard human reference sequence. And the trick in interpreting genetic test results is putting those variants into categories. Are these just benign background variation that does not cause a problem? Are these recognized spelling changes that do cause eye disease? Or is this something completely new that we can't classify yet? And that's the trick of interpreting genetic test results. If it's clear, fine, that's fine. It's when we come back with that middle result, then we're not always providing a really definite answer kind of today, and it may take time, it may take testing parents, it may take just time for the research to evolve so that we can say, okay, we found the cause of someone's eye disease, or actually, this is a red herring. This is just part of normal human variation.
Yeah, I remember a decade or so ago when we were thinking about genetic testing, we sort of assumed it would be clear-cut. It'll either come back as normal or a definite abnormality. But in fact, the group that have variants of uncertain significance, they're the largest group. So this is something I wouldn't have predicted in the past, but now I'm in a position when I do genetic testing where I'll tell many patients, not only do you have this genetic abnormality that's likely causing your disease, you're also a carrier for perhaps 5 other genetic eye diseases in addition. And I would never have predicted that in the past, but it's turning out to be quite a common scenario. So keep in mind that inherited eye diseases, when you look at carrier status, is a lot commoner than anybody can imagine. And when it comes to epidemiology of inherited eye diseases, I think a lot of inherited eye disease genetics has been underestimated in the past because the epidemiology studies that were done were all quite small. And we're all seeing a lot more genetic variation than we were expecting. So it's something very much that we have to take into account when interpreting these sort of results. And that's why I think it's important that molecular genetic testing doesn't become a screening tool. If every ophthalmologist in BC was doing genetic testing, I'd be on the phone every day having to interpret those results for them. Because this is, I mean, when you come to my clinic, you'll see the report is like 14 pages long. And it's not something that's taught in medical schools as yet. So there's a lot of interpretation involved. It's a very, at the moment, it's a very sophisticated testing technology that needs a lot of knowledge, specialist knowledge.
Yeah, now on that note, I wonder what is sort of the process for the genetic testing? So how long does it take from, say, coming to see you, Dr. Gregory-Evans, to actually getting a result? What's the process there, and how long does that take usually for people?
So I think that the Medical Genetics Service, you use Blueprint Genetics?
We use Blueprint, yeah.
So there are a number of companies that offer genetic testing for eye disease. Interestingly, none of them in Canada. And why is that? All of them are outside Canada. Of the ones that are available, most people in Canada who are involved in eye disease use Blueprint Genetics. So this is a company that's based in Oslo. So we have to send your DNA samples abroad. Before that analysis will be done, the province has to approve funding. So we have to put in a special application for every single test that we do. Getting approval from the province takes about a month. Then the laboratory work involved depends a little bit if we're looking for something we are already highly suspicious of, or whether it's a general screen, takes anywhere from an additional 2 to 4 months. So usually we can get a result back within 4 to 5 months.
That's actually not as long as some other provinces, so that's fairly quick. Are there people that choose to do private sort of screening, or is it all done sort of through the provincial system?
It can be done privately, and if people, I've had patients do that. For administrative reasons, I try to dissuade people from doing that. Because, not for medical reasons, but for administrative reasons, I don't have an accountant working for me to take funding in for private testing. So I try to do everything through the province, really. But we do private testing.
Once people have the genetic testing, if they have a result, what is sort of the next step, or what can people do with that result? And then on the inverse, if they don't get a result, what should they consider next? What do they do next? Maybe both Dr. Gregory-Evans and Emily could.
Answer that?
Sure, go ahead.
So when I get a genetic diagnosis back, I always give the patient a copy of their result, of their Blueprint genetic result. I'm not sure that everybody does that, but I do that because often other doctors are interested in knowing what the result was, and I think it's easier to have a piece of paper with it written on rather than for patients to try and remember it. So they have the paper copy. If it's a negative result, I usually say that we will revisit this test in a couple of years' time when the panel of genes that have been screened has been increased. So they're adding something like a dozen or so genes to the panel every year. And I have had patients that have had negative results who've then been reinterpreted a couple of years later. We've been tested, and the result has come back as positive. One interesting test that I had recently was a patient that had had testing done elsewhere that had come back as negative. And this patient clearly had X-linked retinitis pigmentosa. When I looked at the paperwork that he had from his previous testing, that testing hadn't included the RPGR gene, which is the main gene for X-linked retinitis pigmentosa. So we repeated it, and the province agreed to fund it. We repeated it, and it then came back as positive. So retesting is a real thing. If the result comes back as positive, I think that the most important thing for that patient then to do is to become included in the patient registry that is funded and supported by Fighting Blindness Canada. This is a nationwide registry of patients that have genetic eye disease, and importantly, genetic eye disease that has a positive molecular diagnosis. And that is for two reasons. One is that the registry can be used to then support clinical trials for gene therapy and things. But there's another important thing that patients often don't realize. So doctors keep lists of patients. And if you were to go to any doctor, whether it be an ophthalmologist or a GP, and if you ask them, how many patients do you have that have the surname Evans? That doctor would be able to answer that question probably within a few minutes. If you were to ask them, how many patients do you have that were born in 1960? Again, they'd be able to give you that information very quickly. Virtually no doctor would be able to give you a list of patients that they have that have retinitis pigmentosa, and definitely no doctor in the province would be able to tell you how many patients do you have that have retinitis pigmentosa due to the rhodopsin gene. That couldn't be done. The only place that that information is available is the Foundation's Patient Registry across Canada. So when it comes to not just clinical trials, but treatments in the future, like, for instance, you've been hearing about Luxturna, the only way to be able to find patients that Luxturna is appropriate for is through this patient registry. And we're very lucky to have this registry up and working right now. So being part of the registry, I think, is an important thing to do when it comes to getting a positive genetic result back. And the second thing I think a positive result comes back is, it's very nice to know that you have definite retinitis pigmentosa. But there's also great value in knowing that you don't have something else. Before you have a molecular diagnosis, very often there's an element of uncertainty about what is going to happen with your future. But with positive molecular genetics, you can be a lot more certain about what is going to happen and what isn't. And often it's the what isn't is the most valuable bit of information.
Great, thank you. I think we're going to answer a few questions. So if anyone has questions, you can raise your hand and wave at us. Larissa's got the mic. There's a couple. One over here in the middle.
Hi, I have a question for Kevin. So early on, some of these databases did not have ethical approval to recontact a patient for a research study. Does yours have that?
It does. In fact, that's sort of the only function of the registry, is to then recontact patients back. Yeah.
I just have a question about clarifying the process. So I've been very fortunate to have genetic testing twice. Once through your office, Dr. Gregory-Evans, and then once through medical genetics through Blueprint. And the last one was done in 2019. And I had variants of insignificance. And through medical genetics, there was an 18-month waiting period between the referral and being able to see a genetic counselor. And Dr. Evans, I'm Gregory-Evans, I'm going to see you on Thursday. And sorry, can I get a referral for medical genetic testing through you now, Dr. Gregory-Evans, instead of having to go through the waiting period to medical genetics now?
Yeah, I do. I'm doing about a dozen molecular genetic tests a week.
Okay.
So,
I just wanted to clarify, because that process before was through medical genetics. And the frequency. So you were saying that annually they're discovering 12 new genes.
They add about 12 new genes to that panel every year.
Okay.
The other thing is, when it comes to variants of uncertain significance, sometimes they get reclassified.
Okay.
And usually I get contacted by Blueprint to say that this is now thought to be disease causing. And that has happened in the last few years. The other thing is that when you look at variants, the testing doesn't just, so how they determine whether it's a variant. They do it based on what's in the medical literature for a specific variant. Are there people out there already that have disease that's been linked to it? They also do an in silico analysis. Sometimes I look at a variant, and although I can say they're calling it a variant, that's because they're being very careful, because they have regulations, and unless they fulfill a certain criteria, they won't report it. But you have to bear in mind that the literature that they're basing this on is a very American, Canadian, European populations. Mm-hmm. More studies have been done on Europeans. From the surveys that I've been doing from my database, it is clear that I said my success rate overall is 85%. When you differentiate people according to race, Europeans, I get more like 90%, 95% in European populations. But when you look at Eastern Asians and Southern Asians, the success rate drops to 50%. And that's because the literature isn't there for those populations. That will change over the next decade, but that's the situation now. Sometimes you can look at these variants, though, and say, so for instance, if something is a nonsense mutation, a nonsense variant, very often nonsense variants are positive, and they are disease causing. Missense can be a bit one way or the other, but nonsense ones are important, especially if they're a nonsense variant very early on in the gene. So for me personally, when it comes to genetic counselling, I don't really feel as constrained as the companies are. So I'll tell patient, well, this variant is not labelled as disease causing, but probably in you, it probably is. And I leave it at that. So in your situation with variants, the situation may be different now.
And so how frequent, like it is very costly for the province. So what's the frequency of, like, for those that have had negative results in the past to go back and get genetic testing? So the province, so genetic testing done privately, currently, costs $1,600 and a few cents. The province has negotiated, I think, to reduce it so that the province pays only $1,400. And if it's that there's already a mutation known in the family that they then specifically look for, then that cost goes down again. If it's a genetic test that's been done in a family member recently, like I think it's about in the last 6 months, other family members can have it done and the province isn't charged at all. So depending on what group you're in, it can vary from $1,600 to costing the province nothing. When it comes to retesting, the province is still thinking about what to pay for that. They haven't come up with a definite decision as yet.
Yeah, and if someone came to us and said, okay, I had this panel of 300 genes tested 3 years ago, what we would be doing is saying, okay, has anything changed in your medical history? Has anything changed in your family history? Is that pointing us in a new direction? Is there more information we can use to kind of tailor genetic tests to your own specific history? And then the other piece that I would be doing is saying, okay, what's changed on that panel? and do any of those new genes match at all with what that person's history is or their family histories, and that helps us kind of figure out, is it worth doing new testing now, or should we be waiting another couple of years?
Okay, great. I think for time we're going to have to end there, but thank you very much to our panelists. That was a really interesting discussion. Thank you so much.